Hi, I'm Dr. Elizabeth Coyne, and with me I have Hazel Rands, and we're going to do a revision for tutorial 1. So in this tutorial we were looking specifically at the learning objectives to look at contraception options, look at prenatal care, the challenges and assessments involved, and also look and discuss with you intimate partner violence. We had a little bit of a discussion about revision from workshop 1, which was module 1. So in regards to contraception, Hazel, do you want to go through the different sort of methods that we discussed on the day?
Yep. Okay, so with the students that attended the tutorial, we gave them a little bit of an exercise to do, so you can work through that after we've done that. But we basically covered the different types of contraception. So a lot of times people are aware of the names of contraception, but they're not actually aware of the type of method that it is. So we talked about natural methods versus fertility awareness-based methods and barrier methods. So you probably, while you're listening to this, should be looking up some of these to make sure that you're aware of what the differences are. So there's natural methods relating to natural forms of contraception, timing of the month, and it does blur a little bit with those fertility awareness-based methods where you're looking at that ovulation cycle or even continuous breastfeeding. So there's some of those that are included in that. Barrier methods, thinking of things like condoms, female condoms, and then your long-acting reversible contraceptives, so implantable devices, injections, hormonal methods, which include your contraceptive pills, and then some of your more permanent methods related to sterilisation. So big section in module 2 related to that, and then you can have a go at putting these in order from the most effective to the least effective.
Yeah, and it's just important to remember to have a look at this module and the information in relation to contraception in preparation for assessment 3.
Yeah, and just remembering that it's not just midwives who talk to their clients about contraception. In fact, if anything, you probably are more likely to be talking to somebody about contraception in your general medical surgical wards or in general practice or in the community because the deed's already done once they come in and they're having a baby. So we do have some preliminary conversations as midwives with women in care within birthing centres, but generally it's a conversation that's happening outside of the acute hospital setting.
So particularly in relation to prenatal health, there's a lot of those conversations that you might have with the woman and her partner about sort of conception assessment, and as they start to think about developing and wanting a family. There's also screening which can be done. You also have the discussions in relation to substance use, which includes sort of drugs and alcohol. And there's a whole range of different policies in relation to prenatal health that you as the registered nurse need to be aware of.
So there's a lot of these that have been driven by the consumer over many years in relation to what somebody could expect from maternity care services in Australia, especially during that prenatal, perinatal period, or even in those early years when you have small children. So lots and lots of policy that guide care for us as a health professional, but also they are readily accessible by consumers, and that's been the huge difference in maternity care over the last probably decade or so.
So at this stage in the tutorial, we actually sort of really encourage students to have a think about what they might include for prenatal screening and assessments. And then we went through sort of looking at some of the answers, which are all within Module 2. So it's important to have a look at what you might expect as you're sort of going through that assessment. And one of them I think the main thing is to think of what you would do for any patient. You want to have that comprehensive history, which will include past surgical, medical history, also looking at sort of their family history as well. And the other thing is to look at sort of the current pregnancy, and you might also have those discussions about previous pregnancies.
And I guess that the other thing to remember is that we're not preparing you to be midwives, we're preparing you to be registered nurses, but many nurses will care for pregnant women during the course of their career. And so it's not that you would necessarily be doing all of these assessments, but you might need to read a medical history and understand what the types of screenings are, what the additional assessments that we do, and what we're looking at when we're looking at somebody's pregnancy history. And then also to understand what types of things are included in childbirth education. And as I said before, a lot of the changes that have been made in relation to women and their partners and their families making choices about where they're going to birth, who's going to be with them, choices around infant feeding, etc. So a lot of it is that general knowledge that registered nurses need to have, rather than that really specific care that you might deliver as a student midwife or as a midwife.
Yeah, I think one of the things that we discuss with the students of where these type of patients often come in the general areas, and you may definitely would see these patients coming in with miscarriages or nausea and vomiting or just general unwell through the emergency, and they will be at various stages of pregnancy. Also, pregnant women often have to have come in for medical or surgical conditions. They may have comorbidities, but their pregnancy is just part of what we need to be dealing with as a registered nurse. And so it is in part important to sort of really understand what sort of assessments, but use your sort of critical thinking to think about what you're looking at with this woman, because it's that sort of ability to think of what I would be doing for a general patient would then sort of transfer quite well across to a pregnant person, because you're looking at all these risk factors, just thinking that what is she as in the past, what's this pregnancy bring, and then what is she, how to sort of assess and support her for the birth of the baby. And so this is the scenario we went through, and we really looked at sort of different types of data. So just refresh your memory about subjective and objective data, and also sort of what assessment tools could be used. And we had discussed some of these in the workshops as well. And also the health and social issues that may be influencing this particular individual or family. And so it's important to really look at the module, to go through and have a look at the different policies. One of them is in relation to breastfeeding. Other than is in relation to the expected care of a pregnant woman, and also the intimate partner violence.
And so for this woman presenting, as the nurse or the midwife who's interviewing her or completing her assessment, you're going to have some concerns. You know this client and you know that something is slightly different. So as well as thinking about all the standard assessments that you're doing, think about what information or what we know about her current living arrangement or her social situation, and is there anything that's rung alarm bells before, or where would we be thinking about completing further assessments. And some of those policies related to intimate partner violence and even postnatal and perinatal mental health are, again, readily accessible, but also available for health workers to use. So if we just go to the next slide, Elizabeth. So if we haven't already got an extensive social history on this person, sometimes doing a fairly simple, I can't see whether it's the social history one. Oh, this is the Edinburgh one. Yeah, so you might use some sort of social connection scale initially, or you might move on to this Edinburgh postnatal depression score, which is done across the board now in both the prenatal and the postnatal setting. And you can see from it that the questions are quite simple. We will often read this out to the person, or we'll give it to them, or we might need to bring an interpreter in. And you can see that it looks at, those things that make you happy, that you normally get joy from. Has that been affected? Is your interaction and the way you react or overreact to things being changed? And finally, is there anything that, is there a risk of self-harm? So you're really sort of drilling down quickly. This is a bit like your mini mental health assessment, where you're just asking that dozen or so questions and then coming up with not a diagnosis, but rather, I think we've got some concerns here. I'd like to refer you on for some further counselling or treatment. So that's when we would start thinking about planning care.
Yeah, and that's really important to sort of have that, what are the family and the patient's goals? What are they looking for out of this interaction of care? But also, what is your assessment, both subjectively, how she looks, how their family interact, and also our objective assessment. And remembering that often it's included as part of just conversation. It's not like we're going to be sitting there asking them to fill out a form often. It's just, how's your week been? What sort of things have you been looking forward to? Because that starts to give you a sense of how well this woman is going, or your patient in general. And then you may just sort of go into it a more depth. And it's really important as you're looking at planning care of what is the priority of goals as set by the family. So often we as nurses, we have goals that we feel that are sort of your priority, but we really need to put the focus back on the family and what do they see as their priority, what do they see as what they would like us to give them help with. And then the next sort of section we looked at was how we then implement that care. Now, as you know, this is just part of the nursing process, and sort of we just want to reinforce that aspect of looking, developing goals, assessment, implementation, and then evaluation.
So if we're looking at, if we've helped her to set some goals around care, and it may not have been in that interaction where she was quite distressed that you would do that. But thinking about the types of nursing strategies that you might be able to use to support her mental health, so that she can get through the pregnancy healthy, deliver a healthy baby, and have that support. If it's not from her partner, then from other family members or friends. And so it's starting to think about resources, and resources aren't necessarily a physical thing. It might be another person, it might be another health professional, and in most cases where we're suspecting depression occurring during pregnancy or in the postnatal period, we would refer on to somebody for counselling. So that would be the type of resources that we would be looking at. You might give us some printed material, you might refer her to a website. Again, you want her to be accessing evidence-based information. You don't want her to just go Googling things for herself. So it would be really important to give her 1 or 2 sites that she could go and have a look at. Make an appointment while she's there with you to see a nurse counsellor or a psychologist, whatever she's happy to do. She may want to go back and do that with her GP. There may be a history of needing support in relation to her mental health. So again, what would she like to do? What support would she like? And there's also that ultimate question about, do you feel safe to go home before she leaves the service that she's attended? Yeah,
and so it's really important to think about sort of, as you're setting up any nursing interventions, about the evaluation. And so we discuss with students how often our initial assessment then becomes a great way to actually then follow on with that evaluation. So then we went on to actual discussions of what intimate partner violence looks like. And this is also covered quite nicely and in more depth in the module, but you just need to remember that intimate partner violence does cover a range, and I think it's important to sort of be aware of that, the last aspect of controlling behaviours, and this is something that often you may see as the interaction, and so that's where those discussions can start. And so we looked also then at what intimate partner violence does, sort of the outcomes and how they influence pregnancy. And I think one of the important things is to remember that when these discussions with the woman, that to sort of highlight the risk factors, because that then sometimes helps her be a little bit more open, and as you're building that rapport with them, to actually sort of have those discussions. So the questions that we looked at were sort of nice questions to sort of really open those discussions. And it's important to sort of have a look. And Hazel, how would you actually sort of go about including these in conversation?
So this intimate partner violence survey is something that's been available for use for a number of years, and it's recommended to be using. It's recommended to use with women either during their pregnancy or following their pregnancy at some stage. And so these questions You can do them in several ways, depending on how you've developed that relationship. You may just sit down and discuss it with the person. You may give them the written form and ask them to fill it in, so then it's not quite as personal. You may need to include an interpreter, or the person may have a support person with them and they might want to go and complete that together. So you really need to ask the woman, and sometimes it's the man, but you really need to ask the woman, does she feel comfortable with answering these questions? Would she like, 5 minutes to just sit and answer them? And once again, it's trying to address the fact that intimate partner violence isn't always physical. It's very often emotional, it's often coercive, it's often that humiliation or that threatening behaviour without any actual follow through on that. But that's enough to make somebody feel unsafe. So it's really important as the health professional that A, we ask, would they like some help? And B, do they feel safe to go home? So that's always what has to finish this interaction, that offer of assistance.
Yep.
And very often that initial offer of assistance will be refused. And so it is really important to know that they feel safe to go home, or do they have somewhere else that they can go to?
Yeah, and that's where often giving those resources, and even if it's a website that they sort of then can visit and look at sort of more resources themselves. And the main thing to think of as a nurse and involved in having some discussions is to think about your own experience, but also your own self-care. And so this is these slides really look at that what is your response and what strategies do you use in engagement, but how do you actually how do you feel when you hear the women's stories, and how do you manage your own response as if it's in a situation it becomes quite upsetting, and you need to then be able to look at your own self-care and your response to that.
And this is probably something that you're looking at for those of you who are enrolled in or have completed your mental health nursing course, looking at how you respond to client interactions that are threatening or challenging or confronting, thinking about how you might respond, but also acknowledging that your experienced registered nurses and midwives will often either not want you to be present in that initial interaction, or they may want to lead and guide that interaction, even though you're in there and wanting to experience it and have a go at it. It's sometimes not something that you would be responsible for as a student, but you need to have that understanding that even just observing an interaction where somebody has told a story about intimate partner violence or previous trauma can result in what we refer to as vicarious trauma. So you're taking on that pain and emotional anxiety from that other person, and that's quite a normal thing to do. So it's just that heads up that discussions like this can be quite confronting, and even when you're at home working through this tutorial and reading some of the information and some of the further information, you might feel a little distressed and confronted by it, and that's okay. If you need some support, you can always contact us, or we've got extensive student counselling available. So don't ever feel that if you're at some stage in your studies are confronted by what you're seeing, hearing, feeling, learning about, that you talk to somebody about that.
And so then we finished off and talked about workshop 2 and offered time for questions. So thank you.
Thank you, everyone.